A very good evening and welcome, dear all delegates, speakers, and respected Central IP and Maharashtra IP members. On behalf of Maha IP and Women's Committee Maha IP, myself, Dr. Sonali Shirbhate, Chairperson, Women's Committee Maha IP 2023, welcome you all on this session of Tuesday Techs. You all know this month we are celebrating Thalassemia Week, especially on 8th May. So, regarding considering this theme, we had kept the anemias for this as a theme for this session. So, we had welcomed different upcoming speakers from all zones of Maharashtra, and we are bringing them on this platform for their upcoming talent. So, let us move forward. I welcome respected President Dr. Ramakant Patil sir, Honorable Secretary General Dr. Amol Pawar sir, past President 2022 Dr. Hemant Gangulia sir, Vice President Dr. Sham Chaudhary sir, and our esteemed Judge respected Mamta Manglani Madam and Dr. Nitin Shah sir, as well as I welcome all the speakers of different zones of Maharashtra who will be presenting their presentations today regarding the theme anemia. So, welcome you all, as well as I welcome my co-host, Dr. Sucheta Pofre, as well as I acknowledge the presence of Central IIP EB member, Dr. Renu Boralkar Madam, on this session. So, dear all, welcome for this session. Moving further, I would like to tell you about the all zone speakers. Dr. Purva Jain from Raigad IP, Dr. Minal Lavekar from Nanded IP, Dr. Shraddha Kulkarni from Kolhapur IP, Dr. Atish Bakane from Nagpur IP, and Dr. Chetna Bahurupi from Ahmednagar IP. Welcome, dear all esteemed speakers. With this word, I would like to welcome our Vice President, Dr. Sham Chaudhary sir, for their opening remark regarding this session.
Hello, am I audible?
Yes, sir, yes.
Okay. Good evening and warm welcome to all the respected dignitaries, faculty members, office bearers, and all the delegates present on this virtual platform. I sincerely appreciate Dr. Nitin Shah sir and Dr. Mamta Manglani madam for accepting our invitation as experts. I also thankful to Purva madam, Minal madam, Shraddha madam, Chetna madam for accepting our invitation as a faculty members. I am sure this webinar will empower us to, while handling the anemia cases, to handle it with more confidence and accuracy. I wish you all the best. Over to you, madam.
Thank you, sir. Thank you for your kind words. I would like to invite Dr. Hemant Gagulia sir, who is past president Maharashtra IP 2022. Sir, I request you for your opening remarks for this session.
Thank you very much, Dr. Sonali Madam. Good evening, the respected dignitaries, today's judge, Dr. Nitin Shah sir, Dr. Mamta Manglani Madam, presenters, office bearers of Maha IP Women Committee, all attendees on this Zoom as well as YouTube, each one and all. It's very happy to know that Tuesday Takes, which took off last year, continues this year with a great bang, a concept which arose from one of the T20 series session of Mahapadikon 2019, which was held at Amravati, of which myself was the part. And all credit goes to the Maha One committee, who really formed, which was formed last year. And then it was Dr. Renu Madam. Now today is this year she is EB. Dr. Renu Madam, Dr. Sonali Madam, who took that lead to organize this Tuesday Takes. And now this year is Dr. Sonali, Dr. Neha Singh, as well as Dr. Manjusha as the convener of this Tuesday Takes of the Mahaipi committee. And all 10 zonal committee members who are the part of this Mahaipi committee, hearty congratulations to all of them to organize such a fantastic, nice session. And hearty congratulations to them, and I'm sure it will be a great learning session. The concept is that whatever we'll be hearing in 5 minutes, the gist of the knowledge regarding the topic, which will be helpful in our general practice as a general pediatrician. So And I'm extremely happy to know this young upcoming talent are taking the part in this. All the best wishes to all 5 speakers, Dr. Purva, Dr. Meenal, Dr. Shraddha, Dr. Atish, and Dr. Chetana. All the best wishes. Thank you very much.
Thank you, sir, for your kind words. I acknowledge the presence of our MMC observer for today's session, Dr. Prashant Bhadane, sir. He is a pediatric cardiologist from Nagpur. As well as I am very thankful to Dr. Manjusha Sherkar, madam, convener Women's Committee, and Dr. Neha Singh, co-chairperson Women's Committee, as well as Dr. Sucheta Pofre, madam, for working hard for this session. With this word, I would like to hand over mic to Dr. Sucheta. Before that, I would request Dr. Mamta Manglani, madam, to our expert judge for this session to have few words about this session.
Thank you, Dr. Sonali, and congratulations to MAHA-AP and the Women's Committee for having organized all women speakers session today. And it's so heartening to see all young people here who are presenting their topics. And I would like to, of course, acknowledge Dr. Shyam Chaudhary, Dr. Hemant Gangolia, Dr. Manjusha, Dr. Renu Boralkar, Dr. Sucheta, Dr. Neha Singh, and all the other office bearers who may not, I may not take names because of lack of time also, and I don't want to miss out on anybody. So everybody who's here from MAHA-AP for a wonderful, educational series that you have started. So today's session, as you have rightly chosen on the occasion of World Thalassemia Day, it is anemia in pediatric practice. And of course, we will be focusing more on the practical points so that you can utilize those messages in your office practice. But let me also make a mention of the World Thalassemia Day. As you know, thalassemia is such a dreaded disease. So sorry, Atish is the odd man. Sorry, Atish. I must acknowledge you are there. So yeah, you have to balance with one person at least who's the odd man out. We call them odd man out anyway. So when you talk of World Thalassemia Day, this time the theme was be aware, share, care, and strengthening through education the thalassemia care gap. And that's exactly what we have been doing since the last 1 month. There have been so many sessions all across Maharashtra and India, and under the leadership of our present President 2023, Dr. Upendra Kinzavadekar, who has a passion for thalassemia because he belongs to our institute and has worked with Dr. Lokeshwar and myself. So I'm sure he is very passionate about it. And we have released the guidelines also this year under the IAP-PHO chapter, which will be available online within maybe next 2 weeks to everybody who wants to purchase one. All thalassemia centers will be given one copy free of cost. And we will definitely like that the knowledge be disseminated and proper, comprehensive, holistic care is imparted to all children with thalassemia. But more than imparting comprehensive care, it's important to prevent thalassemia. So I urge to all of you to spread the message of prevention rather than just care. Care, cure, and control. All three should go hand in hand. Cure, as you know, is with HSCT, which we'll be talking today. Atish is an expert on that. I think he is a real expert who's going to speak on his own topic. And anemia as such, sickle cell is a very important aspect today in India because, Mission 2047 has been launched during the budget session by the finance minister. And we are having good amount of funds available today to control sickle cell anemia across the country. So it's important that we learn about sickle cell also. Nutritional anemia is absolutely a topic which is a hot topic every time we talk of it. And we have then 2 other topics, that is bone marrow transplant as well as aplastic anemia, immunosuppressive therapy. So these are the topics, and of course, blood products, how not to make errors in transfusion. So I think with these words, I will not come between the session and you who are attending. Once again, thank you for inviting me. It's a pleasure to be amongst you all. Thank you.
Thank you, dear madam. Our president, Dr. Ramakant Patil sir, and our secretary, Dr. Amol Pawar sir, are busy in another session. They will be joining soon. So we will continue the session. Over to you, Dr. Sucheta madam.
Yes. Good evening all. Thank you to the organizers for giving me chance to moderate this session. and a very Herculean task is given to me to introduce Mamta Manglani ma'am in just very few words. That's almost impossible, but I'll try my best. Madam is currently working as a director of comprehensive thalassemia care, and she is a pediatric hemato-oncology and BMT center at Mumbai. As a professor and HOD, Madam has headed pediatric and hematology department of LTMC Sion for many years. She has held many posts like President Mumbai IIP, President Pediatric Hemato-Oncology Department, Chapter of IIP 2019, Executive Board Member for BBIIP. She was convener for various committees of IIP and task force. She was a member of Working Group of Care for HIV Children by Minister of Health and Family Welfare by Government of India. She is a founder member of Gene and Cell Therapy Society. Madam is interested very much in research also. 17 research projects nationally, and she has collaborated in 5 international research projects, and that is a huge amount for the research. Madam is an excellent orator, and she has 8 prestigious orations to her credit. A true academician. You cannot imagine 568 whooping publications with 19 award-winning papers. That is such a huge number. She has shouldered the social responsibility also by establishing state-of-art the pediatric HIV care centers, hemophilia centers, as well as several daycare transfusion centers. In short, she is the backbone of our thalassemia and HIV care.
Hello.
Yes. So, to मैडम का अगर 1-2 वर्ड्स में बोलना चाहे तो मैडम के बारे में इतना ही कहूंगी मैं, बस नाम ही काफी है मैडम का. हाँ. So, am I audible?
Yes, madam.
Yes. Dr. Nitin Shah sir, he will be joining soon, and he is also a legendary figure in the field of vaccinology as well as hemato-oncology. He is a former IIP president in 2006, a dedicated teacher, a relentless researcher, and a huge resource of knowledge and wisdom for vaccinology and hematology. Sir, hopefully sir will join soon. Now, our Tuesday Ticks is a popular series of short, crispy, and time-bound sessions, and it gives platform to the young talent from Maharashtra. So my request to all speakers is hit the bullseye in just 8 minutes. So, Dr. Sonali, can we start with the session?
Yes, madam. Before that, our MMC observer, Dr. Prashant Badane sir is here. Would like to request him to have a few words for us. Dr. Prashant Badane sir. Dr. Prashant Badane sir.
Pallavi ma'am, have you please give him the permission to unmute?
Yeah, ma'am. Already given.
Okay.
Hello, am I audible?
Yes, sir. Yes.
Yeah. Without wasting any time, we should just proceed with the proceedings. Okay. Yes. Thank you.
Thank you, sir.
Okay. So our first speaker is Dr. Purva Jain from IIP Raigad. She is a lecturer at MGM Navi Mumbai Medical College, and she is a pediatric consultant at Medisure Hospital, Karjat. So, Dr. Purva, you can start, please.
Thank you so much, ma'am, for the introduction.
Dr. Purva, please share the screen.
Yes, actually.
Ma'am, your presentation is open. You need to only click on the share screen button.
Yes, ma'am. Actually, that's not coming on the screen. Just 1 second.
Share screen button is visible to you or not, ma'am?
Yes, yes, ma'am. Now just 1 second.
Okay, okay. Yes, ma'am. It's visible. Make it full screen only. Thank you.
Yes, ma'am. Is it full screen now?
Yes, yes.
Yeah. Good evening, everyone. I will start my topic. My topic is how do I treat the sickle cell disease? Introduction. Sickle cell disease refers to autosomal recessive group of disorder caused by a qualitative mutation in the genes encoding the beta globin chain of an adult hemoglobin. Just 1 second, hold on. Actually, it's yes. This abnormal hemoglobin, known as a sickle cell hemoglobin, on deoxygenated form on a polymeric structure, resulting in a deformed rigid red blood cells, leading to chronic hemolytic anemia and a vaso-occlusion. It encompasses a homozygous sickle cell anemia, sickle cell hemoglobin C, sickle cell beta thalassemia, and other compound heterozygous conditions such as sickle cell D Punjab, sickle E thalassemia, and sickle alpha thalassemia. Sickle cell belt of India spans across states of Gujarat, Maharashtra, Madhya Pradesh, Chhattisgarh, West Bengal, Odisha, and Andhra Pradesh, with the prevalence of heterozygotes ranging from 1 to 40% in many tribal population. The diagnosis is based on newborn screening, HPLC, and genetic mutation analysis. This is a short picturization of pathophysiology and symptomatic profile. There's the effects of a vascular occlusion on one side and the effects of chronic hemolysis on the other side. The effects of vascular occlusions are stroke, retinopathy blindness, acute chest syndrome, renal infarcts, autosplenectomy, aseptic bone necrosis, osteomyelitis, leg ulcer, and dactylitis. The other side is a congestive cardiac failure, jaundice, chronic hemolytic anemia, and pigment stone. There are 4 types of crises seen in SCD: sickling crisis, hemolytic crisis, aplastic crisis, and sequestration crisis. These are the list of investigation which is required before any management or treatment part. CBC with reticulocyte count, extended blood grouping, HPLC of the patient and the extended family, HIV, HBsAg, HCV, RFT, LFT, and G6PD test. Before starting on the management, I will go through with the standard of care. Disease modifying agents are hydroxyurea, pain management on analgesics, acetaminophen, NSAIDs, opioids. Prevention and treatment of infection is prophylaxis with penicillin V and erythromycin. Supportive care includes IV fluids, PRBC, partial exchange treatment, iron chelators, and appropriate immunization. Followed by prevention of stroke and management of pulmonary hypertension, folate and zinc supplementations, and management of any other complication. So sickle cell disease should be considered as a chronic, long-term, and a life-limiting condition with acute exacerbations that have far-reaching disabling consequences for the child and the family. Hence, it requires a multidisciplinary and a comprehensive teamwork to provide optimum treatment of health maintenance, acute care, and monitoring of disease-modifying therapy to SCD patient. This team consists of pediatrician, hematologist, immunohematologist, intensivist, psychologist, and social workers. First, followed by a non-pharmacological measure, parent education about disease, complication, treatment, and cure of SCD, advice to maintain hydration, avoid extreme cold, heat exposure, and heavy exercises, diet rich in omega-3 fatty acids, vitamin A, and zinc may be advised. There's no role in vitamin C and E or a sodium bicarbonate. Immunization in sickle cell disease, apart from all routinely recommended vaccines, children with SCD must be administered pneumococcal, both conjugate and polysaccharides, Haemophilus B, H influenza B, meningococcal, and typhoid vaccine as per IAP guidelines. Antibiotic prophylaxis, oral penicillin V prophylaxis should be offered to all SCD patients starting from 90 days to life of 5 years of age. Continue prophylactic penicillin beyond 5 years of age if the child has undergone a splenectomy or had an invasive pneumococcal disease. This is a dosage of penicillin: less than 1 year, 62.5 mg, 1 to 5 years, 125 mg, more than 5 years, 250 mg. So now the role of hydroxyurea in a sickle cell treatment. So hydroxyurea is a mainstay in overall management of sickle cell disease since it reduces the incidence of acute painful episodes and hospitalization rates and prolonged survival. In infants 9 months of age and older, children and adolescents with SCA offers treatment with hydroxyurea regardless of clinical severity. So dose is 10 to 15 mg per kg per day, single dose. Monitor the counts every 4 weekly initially to maintain about absolute neutrophil count more than 2,000 and a platelet count more than 1 lakh. The dose may be escalated gradually to maximum of 35 mg per kg per day if indicated clinically. In case of neutropenia or thrombocytopenia, withhold the drug, monitor the counts weekly till recovery and restart at a lower dose. Continue to monitor CBC, reticulocyte count, RFT and LFT quarterly once a stable and a maximum tolerated dose is achieved. Folic acid to be administered 1 to 5 mg per kg per day, 1 to 5 mg per day to all the children. These are the indications of blood transfusion sickle cell disease. In the acute condition is a clinical stroke, chest syndrome, acute symptomatic anemia, parvovirus infection, splenic or hepatic sequestration, pregnancy and preoperative. While for the long-term transfusion therapy, primary or secondary stroke prevention, recurrent acute chest syndrome, recurrent vaso-occlusive crisis, pulmonary hypertension and progressive organic failure. Iron overload. Patients for chronic blood transfusion therapy develop mainly hepatic iron overload. Cardiac and gonadal damage is uncommon in sickle cell disease. Serum ferritin can be used for monitoring iron overload. LIC can be measured by T2 MRI for the patients more than 10 years of age. Iron chelation should be initiated after 10 to 12 transfusion. Serum ferritin more than 1000 microgram per liter. LIC more than 7 mg per kg dry weight of liver. And desferoxamine and deferox are the main licensed drugs which are used for the iron overload and SCD. Management of acute complications. These are the red flag signs to consult on a healthcare facilities. First, acute severe febrile illness, newly palpable spleen or increasing size of a previously enlarged spleen, significant respiratory symptoms, severe abdominal pain, neurological symptom, priapism lasting more than 4 hours, significant increase in phallar, fatigue, lethargy or jaundice, pain not adequately controlled by home medication. So first we'll start with the acute pain crisis. Assess the pain intensity using a visual analog scale. Identify and avoid factors that regularly trigger pain. Mild to moderate pain can be managed at home. Patient presenting to emergency should receive optimal pain relief within 30 to 60 minutes of admission. The longer the pain persists, the more challenging is to control the pain. So use a step-down approach instead of step-up approach. Risk of opioid addiction should not be grounded to the withhold opioids. So these are the treatment part, which includes paracetamol, ibuprofen, codeine, tramadol, morphine, and ketamine. So the dose is given in this treatment. Yeah, this is the algorithm. If in a clinic or office setting, we suspect a pain, there are the signs of other complications. If yes, then transfer to the emergency department. No, then can the pain be managed in a clinical day hospital setting or other short-term stay hospital setting? If it's no, then transfer to the emergency department. If yes, then treat the pain in clinic or transfer to the alternative center. First, triage as high priority in an emergency department. Evaluate for complication on arrival. Begin analgesic treatment within 30 minutes of triage or within 60 minutes of registration. And treat pain aggressively and promptly. Administer first dose prior to possible within 30 minutes of arrival. Administer opioids per patient specific protocol. IV route subcutaneous when IV not available. And reassess the pain every 15 to 30 minutes and use non-pharmacological approach such as the heat. Next complication is acute febrile illness. Children with sickle cell disease are immunocompromised due to splenic hypofunction and are at risk of life-threatening infection, particularly with encapsulated organisms. Single oral temperature of more than 100.4 degrees should be treated. A CBC, reticulocyte count, blood culture, and other specific tests should be done to look out for the focus of infection. Empirical parental antibiotics are required to all children with SCD with fever. Ceftriaxone should be given within 1 hour of fever. Other complications are clinical stroke, can present with focal neurological deficits, IV hydration and exchange transfusion to reduce HbS to less than 30% of a total hemoglobin. ACS, acute chest syndrome, presents as a fever, pain, and dyspnea with new radio density on chest X-ray can be triggered by infection. Immediate management is an effective pain control, adequate oxygenation, empirical antibiotics, a macrolide plus third generation cephalosporin should be given. blood transfusion or exchange depending on the hematocrit. Acute anemia, a sudden drop in HB can occur due to transient aplastic crisis, hyperhemolytic crisis, or a splenic sequestration. This is a flow chart. When there's a sudden drop in
Purva?
HB. Yes.
We should stick to our time. We have 9 minutes complete.
Yes, ma'am. The last few slides are there. Yes, 2-3 slides last, ma'am. Yes. So, a sudden drop in HB. There's a rapid enlargement of spleen size. Yes. Then splenic sequestration is there. So rapid correction of hypervolemic or PRBC, and we require emergency splenectomy. Otherwise, then we depending on the reticulocyte count. Curative management, everyone knows, hematopoietic stem cell transplantation, monitoring of a child with sickle cell disease, regular growth monitoring, monitoring of a nutritional status, maintenance of a pain crisis diary, regular palpation spleen of an older children. This has to be done, this all points, CBC, RFT, LFT, transcranial Doppler, BP and oxygen saturation measurements, PFT, 2D echography, urine analysis, HIV, HBs, HCV, and MRI, T2 MRI, ferritin. These are all points to be monitored as child with a sickle cell disease. Yeah, this is the last slide. Role of a prenatal testing in a sickle cell disease. Prevention of a disease can be done through carrier identification, genetic counseling, and a prenatal diagnosis. And then indications for a tertiary care referral is acute and complicated sickle crisis, routine comprehensive multidisciplinary care, and genetic counseling, and pregnancy. The few future perspective are crizanlizumab, voxelotor, and L-glutamine and gene therapy. So this is a slide for a novel agents in the management of a sickle cell disease, L-glutamine, voxelotor, crizanlizumab. Thank you.
Thank you, Dr. Purva. We know it's very hard to cover all the topic in 8 minutes, but that is the dictum of this Tuesday.
Yes, yes.
Dr. Mamta, ma'am.
Yeah. So, yeah, thank you. So, Purva, it was a wonderful presentation. I must compliment you. And within such a short span to cover almost every aspect of sickle is very difficult, and you did it. So good.
Thank you so much, ma'am.
You just overshot probably by a minute, but that's pardonable. Now, certain points that I like everybody to know about sickle cell disease is that, first of all, tribals have less severe sickle than non-tribals. And that's something which we must be aware, because these tribals who do not seek treatment also do well. But a non-tribal sickle should get proper treatment always. Of course, tribals should also get, but sometimes they may escape treatment and still they do quite okay. The second thing that in India, we have the Arab genotype, which leads to this non-severe in the tribals, whereas the African genotype is the one which is the severer one. Hydroxyurea is a wonder drug. I think it's a miracle which has been discovered for sickle cell disease. And we have all been using it regularly in all patients. At 9 months onwards, every baby who has been diagnosed on newborn screening as sickle should be given hydroxyurea by 9 months of age, because it improves the splenic function as well as renal function in those patients, even in whom there is no vaso-occlusive crisis. So do not forget to start hydroxyurea in every sickler who comes to you. Of course, you have to keep in mind that you have to monitor the patient while on hydroxyurea for CBC, LFT, RFT, which you've already alluded to. I'll not go into details. The flip side is that at 9 months, when you want to give hydroxyurea, it is available only as capsule of 500 milligram at present in India. There is a 250 milligram capsule which is going to be marketed soon by a company. And there is also syrup which is going to be available in the market soon. So that is another point which is important to note. So if you have to give the capsule, you can open up the capsule, dissolve the 500 milligram content in distilled water 5 ml, and use whatever you need and keep using it over 24 hours to 48 hours. But discard after 48 hours whatever is remaining. So that is how one can use hydroxyurea. Now, one thing which I want to say is that infants do develop hand-foot syndrome, which is very typically seen in first year of life, which is dactylitis due to vaso-occlusive crisis. So one should not think this is just edema of feet and hands. In a patient who is likely to be sickle, think of a hand-foot syndrome and treat him for vaso-occlusive crisis as soon as you see that. Routine measures of avoiding dehydration and diarrheal diseases being promptly treated in these patients, telling them to take plenty of oral fluids routinely, and avoiding high altitudes like trekking. I would share one patient's story. He was doing very well with hydroxyurea, was 12-year-old, a healthy child then, and only child of the parents. Mother had undergone tubal ligation, and this child was doing well, so she was very happy. One time they went to some place for trekking, and he came back with acute chest syndrome, got admitted in PICU, and we could not salvage him. So she lost the only child. So it's extremely crucial to give these advices to every child of sickle cell disease when you see them in your practice. So that's another thing which is important. Transcranial Doppler should be annually done for every child with sickle cell disease after 2 years of age to know whether they are predisposed to stroke. And if they have more than 200 millisecond speed in the MCA, then you must put them on transfusion therapy, chronic transfusion therapy, because only hydroxyurea doesn't help prevent stroke. And all these patients who go on transfusion therapy are candidates for transplant, because they are the ones who are going to develop a lot of complications related to transfusions, and multiply transfused patients are always candidates for transplant. Gene editing with BCL11A gene being tweaked has been shown to improve the hemoglobin F content, and hemoglobin F content, when it is high, it helps sicklers to have milder manifestations. So these are certain things which are now in vogue in the future, gene editing, and the 3 drugs that Purva alluded to. The crizanlizumab has already been approved for use. Voxelotor has also been approved for use, and glutamine. Glutamine, I think, is the least useful. I have tried in few patients, not found great. Crizanlizumab, though it is expensive, is worth trying in some patients. So I think with these few messages, I close the comments for the first presenter. Over to the next presenter.
Yeah. Thank you, ma'am. Your words are like gospels of pediatric hemato-oncology to us. And our second speaker, young speaker, is Dr. Meenal Lavekar. She is a consultant pediatrician at Lavekar Hospital, Nanded, and formerly a lecturer at Miraj and Manipal Medical Colleges. Over to you, Meenal.
Good evening, everyone. Today, I'm going to speak about the topic nutritional anemia. And more precisely, I would like to speak on the topic, how do I treat and prevent the iron deficiency anemia?
I think you reshare it. Stop share and reshare it.
Yeah. First of all, I would like to tell about what is nutritional anemia. As we all know, the nutritional anemia is mainly a condition in which the hemoglobin content of the blood is lower than the normal as a result of deficiency of 3 essential micronutrients, that is iron, vitamin A, and iodine. So moving quickly to the iron deficiency anemia, which is the topic and which is the most important topic of the most important thing for today. So why we need to stress so much upon the iron deficiency anemia? Iron is more important for the growth and development. It also helps to move the oxygen. It also helps in the oxygenation in our body. Iron in the human body, most of the adults it is 3 to 5 grams. In children, it is 55 milligram per kg. Most of the iron it is stored in the hemoglobin, that is 70%. Body stores are 26%, and in the muscles it is 3.9%. So next, coming to the topic, like how do we diagnose? How do we diagnose this iron deficiency anemia and why it is important? As we all know, this iron deficiency anemia is widespread and most common nutritional disorder in the world. 30% of the global population is estimated to be suffering from this iron deficiency anemia, and most of them are living in the developing countries. So diagnosis basically on the 2 things. One is a clinical diagnosis, other is a laboratory diagnosis. Clinical diagnosis, as we all know, most of the patients come to the OPD telling about the pallor. The symptoms of the pallor which are complained by the patients are like the child is not eating well, the child is feeling very fatigued, the child is irritable, the child is dull looking. All these symptoms will indirectly tell you that the pallor or the symptoms are there. The second most clinical thing which we all need to know is the pica. Pica is something, as you all know, eating of the non-nutritional things. The parents typically complain the child goes and eat the chalk piece, the child goes and eat the non-nutritional things which has to be eaten. These are some of the clinical features which will tell that the child may be suffering from iron deficiency anemia. Next, coming to the laboratory diagnosis. The lab diagnosis, as we all know, is not very difficult to diagnose the iron deficiency anemia. Two simple tests are mainly
I think her connection is lost.
Yeah.
Network issue. Yes.
Mm.
Shall we call her?
Yeah, someone must tell her.
She has left.
Till that, Suchita madam, we can take the another speaker. Suchita madam, we can take third speaker, I think.
But what about her then? Shall we?
Not picking up the call.
No, no, she has picked up. She has asked for a minute time. Shall we give her 1 minute? Can we take her up to last?
Yeah, we can
She's
take
able
her.
to join. Yeah. 1 second. Okay. So shall we skip the comments, or ma'am, we like to hear?
I think we can have the comments after her completing the topic.
Okay.
Yeah.
Okay. So our third speaker is Dr. Shraddha Kulkarni, Associate Professor at GMC Kolhapur. And Dr. Shraddha, please proceed.
Thank you, ma'am. Good evening, everyone. Are the slides visible?
Yes.
So my today's topic is blood products transfusion errors. Blood transfusions are life-saving treatments, but if the processes are not followed, grievous errors can lead to sentinel events. In a study conducted, the overall error frequency per 1,000 requisitions was found to be 2.26. So transfusion errors can lead to adverse reactions, immune-mediated, non-immune-mediated, right from near misses to severe effects. The various components which can be transfused are cellular, plasma components, and plasma derivatives. So the errors can occur from any step, right from the recruitment of blood till the completion of the transfusion. For safe blood, it should be accepted only from a voluntary, non-remunerated, healthy donor. Appropriate tests should be carried out to rule out the infections. Especially NAT is advisable as it lowers down the window period of HCV and to some extent of HIV. Use of leukodepleted RBCs, gamma irradiated blood products, and CMV negative blood products make the blood more safer. In cases where their facilities are not available, bedside leukodepletion filters can be used. In the blood bank, temperature should be maintained properly. For pre-processed or processed blood, it's from 2 to 6 degrees, whereas for FFP and cryoprecipitate, it should be maintained below 30 degrees. So let's see some examples of transfusion errors. A patient was brought from ambulance. Accompanying Dr. A handed over the unlabeled blood samples to Dr. B, stating that they are patients. Dr. B labeled them and issued PCV for the patient. And patient got reaction after starting transfusion. So it was found that the samples were not of the above patient, but some other patient whose blood was drawn at the same time by Dr. A, and the samples got interchanged. So Never pre-label the tubes, neither keep the tubes unlabeled after collection. The doctor or staff who draws the sample himself should label it, and never draw samples from more than one patient at the same time. Few common errors can happen during patient identification, blood orders, wrong blood type, wrong blood labels, lack of informed consent, and no cross-match completed. If we analyze, the root causes can be either communication barrier, no standard operating procedure, technology, training, equipment barriers, or multitasking. Apart from this, neonatal transfusions are challenging because as there are no antibodies, reverse grouping cannot be performed. The blood should be compatible with maternal serum also. In cases of high volume transfusions, and if you are using SAG-M blood, which contains mannitol, monitoring should be done keenly, and multiple transfusions in preterms can increase the risk of ROP and alloimmunization. So before transfusion, ask yourself what, whether required, how much required, actual component required, and time duration of transfusion. For whether required, stick to the standard guidelines for PCV, FFP, and platelet transfusion. For PCV, the amount should be 10 to 15 ml per kg and the rate up to 5 ml per kg per hour. So the transfusion should finish within 3 hours. For FFP and platelets, the rate is more rapid. Don't use syringe pumps or infusion pumps as they cause mechanical destruction of the cells and they don't have filters. No need to give furosemide, just subtract the amount from the total fluid and use small volume aliquots for neonates to avoid the wastage. Let's say another case, a 10-year-old female child with internal bleed following blunt trauma, doctor orders for 1 bag of whole blood. So whole blood may seem appropriate, but by the time tests are done on it, there is depletion of coagulation factors. Hence, administering RBCs, factors, and platelets together maintains the physiological constitution of blood rather than the whole blood itself. So in cases where massive transfusion is required, such as hemorrhage or ECMO, massive transfusion protocols should be used, which have a predefined ratio of RBC, FFP, and platelets, usually in the ratio of 1:1:1. Transport from the blood bank should be done maintaining the blood cold chain. For FFP, dry ice can be used. At the bedside, identify the correct patient by wristbands or asking name. Take informed consent in the patient's own language and ask for the blood group if known. Inspect the blood bag for blood clots, bacterial contamination, or change in color. Here, right side, you can see that the color has changed to purple, which means hemolyzed blood. Such bag should be rejected. Let's say another case, platelets were issued for a patient at 3 p.m. but he was taken for emergency USG same time. Hence, platelets were kept in the ward fridge till patient returned. So, platelet transfusion should be started within 30 minutes from the time they are released from the blood bank. They should not be kept in fridge or ice-packed containers. Even PCV should not be kept in the ward fridge. Platelet concentrate should be stored between 20 to 24 degrees with continuous gentle agitation to prevent platelet aggregation. Another case, FFP was issued at 5 p.m. but kept in a ward freezer till next morning. Later was removed and thawed in hot water tub at the bedside before transfusion. So ward fridge freezers can't maintain the temperature below 30. And FFP once thawed should be given within 30 minutes. Standard thaw baths should be used because they maintain the temperature at 37 degrees for thawing. Monitoring vitals during transfusion. Pre-transfusion vitals should be taken, then every minute for first 5 minutes, followed by every 30 minutes till the completion. Patient should not be left unattended during transfusion, and in any reaction, transfusion should be immediately stopped and treatment should be initiated. Standard blood transfusion sets should be used. Blood warmers are not required routinely except in cold antibodies. Only isotonic normal saline is compatible. Do not prime the set with 5D or ringer lactate. Dextrose will cause hemolysis and calcium in ringer lactate will cause clot formation. Platelets should not be transfused with the set used previously for PCVs, and drugs should never be added to a blood component bag. So the 7 steps to a safe transfusion should be followed to avoid the transfusion errors. First is appropriate indication for blood transfusion, correct patient identification, bedside labeling of the sample, check previous transfusion records, proper collection and inspection of blood, correct patient identification at bedside, and monitoring the vital signs during transfusion. To err is human, but to avoid transfusion errors is divine. Thank you.
So,
Thank you. Oh,
yes, please go ahead.
Thank you, Dr. Shraddha. And it is said that if you want to talk for any subject for an hour, you need preparation in days. And if you want to talk for 30 minutes, you need preparation in weeks. But if you want to talk for 8 minutes, preparation is needed for at least a month. So we all are preparing for a month, particularly the speakers have tried very hard and very good presentation. Now, ma'am, over to you for your expert comments.
Yeah, thank you, Sujita. I think well said. You know that you need more than a month. In fact, I always tell my students that when one presentation I have to prepare, it takes me 25 hours for a 25-minute talk. So it is tough. So well done, Shraddha. You really incorporated good number of changes also after we had the discussion, and your slides were wonderful. So you've covered very many things. So I don't think there's much I want to add except for a couple of points. One is that we use leukofilters for RBC transfusions, which we are all aware of and which you also alluded to and spoke of. But there are platelet filters which are specific to platelets, and where you can remove the leukocytes from a platelet pack also. So ask for specific platelet filters if you want to give leukodepleted platelets to a patient who's either peri-transplant or who's immunocompromised or is a neonate, a preemie especially, very low birth weight. Use those. Of course, one thing which everybody must be aware is that having a transfusion reaction is one part. Managing it efficiently is the second part. But reporting back to the blood bank is a very crucial part of the whole process. And when you are reporting, you have to fill an adverse reaction form. And along with the form, you not only send the remaining blood from in the blood bag or return the blood bag, which is having the remaining blood. Even if there's no blood in the blood bag, you return it and collect a sample EDTA as well as plain from the patient freshly and send it again to the blood bank, because they will test for Coombs test. They will look for again grouping, cross-matching, whether there was a mistake in the grouping, cross-matching, etc. About platelet bags being kept in the fridge, it's a big no-no. Always platelets have to be kept in air-conditioned room temperature, that is between 20 to 24 degrees, and always in an agitator. So if we do not have these facilities, then don't get the platelets out from the blood bank early. Allow the blood bank to leave it with them till you want to transfuse. As soon as a platelet bag comes to you, you must transfuse it within 15 to 20 minutes, not even 1 hour, I would say, as early as you can. It can be infused, in fact, people say, directly. You need not even hang it up. Whereas for packed red cell transfusion, there is a misconcept. In thalassemia patients, I have seen so many people just giving 1 bag at a time. They say, how can we give 2 bags, 3 bags? It does not depend on number of bags. It depends on the weight of the patient. So calculate the required amount as 15 to 20 ml per kg of packed red cells of a hematocrit of 65% to be given to any thalassemic child, adult or child, over 3 to 4 hours, because you can infuse at the rate of 5 ml per kg per hour. That is the way you must transfuse. Leuko-reduced blood is preferable. Pre-storage reduced is better. And you must also not give this rate if the patient has a cardiac problem. So that also has to be kept in mind. If there's cardiac failure, impending cardiac failure, cardiomyopathy, then the rate should not exceed 2 to 3 ml per kg per hour. I think these were couple of things which I thought, and informed consent has to be taken each time a transfusion is given. So in thalassemia patients, what we do is we create a page for 1 year and take their signature every time for that particular date, so that you don't every time speak out the whole informed consent, but at least signature is documented every time. Even that, according to rules, is not permitted, but to make life easier for them and for us, we do that. But you must always take consent for a blood transfusion. So with these comments, I will stop. Over to you, Sucheta.
Yes, ma'am. Your simple words of knowledge and wisdom make our task very simple, ma'am. At least it seems to be very simple. Dr. Sonali, Shall we?
Yes, Dr. Meenal, have you joined?
Unmute yourself. Dr. Meenal, unmute
Yeah,
yourself.
I have
You
joined.
can try share screen.
हाँ, ठीक है मैम
You
आप
can continue.
Just a minute, I'm sure.
Yeah. Is the screen visible?
Yes, yes.
Sorry for the interruption. As we were on the nutritional anemia, I would like to continue the same topic. As I had told, it is condition which is called by the low hemoglobin content of the blood, which is called by the three essential micronutrients: iron, vitamin A, and iodine. So coming to our today's topic, that is iron deficiency anemia, the treatment and the prevention. Why iron is so important? Why are we so much bothered about the iron? It is because iron is needed for the growth and development of the children. It's also needed for the oxygenation of the children. So what is the iron content in the human body? The iron content in the adults, it is 3 to 5 grams. In the children, it is 55 milligram per kg. The hemoglobin contains maximum iron, that is 70%. Body stores are 26%, and muscles is 3.9%. So now coming to our next thing, that is diagnosis of the iron deficiency anemia. As we all know, iron deficiency is the most common, widespread, and the common nutritional disorder in the world. 30% of the global population is suffering from this iron deficiency anemia, and most of them live in the developing countries. Clinically, as I had already discussed, it's basically clinical and laboratory diagnosis. Clinical is the basically pallor and the pica. The pallor, the patient usually complains that the child is very lethargic, very dull, not playing, not mixing with anyone, not having proper food. All these are the basic complaints which the parents come with. And pica, the parents typically complain that the child eats a non-nutritional thing which they are not supposed to eat. For example, most common is a chalk. Laboratory diagnosis, it's very simple. It's basically the complete hemoglobin picture as well as the iron studies. The complete hemoglobin picture, it shows the low hemoglobin with the reduced MCV, MCH, MCHC, and RDW is increased. Blood film shows microcytic hypochromic anemia with anisocytosis, and the blood count is thrombocytosis is usually present. Serum ferritin level is reduced, serum iron level is reduced. This is how the peripheral smear of the iron deficiency anemia looks like. So the laboratory findings in the progressive iron deficiency anemia, there is a sequence of biochemical and hematological events that occur. Clinically, the iron deficiency is not very difficult to diagnose. First, the tissue iron store, that is the ferritin, is the first one to get depleted. Next, the serum iron levels get depleted, and the transferrin and the protoporphyrin levels are increased. At this point, when the protoporphyrin and transferrin levels are increased, then it becomes an iron deficiency anemia. With, as I had already told, that MCV, MCH, and MCHC, all three are reduced with the elevated RDW. But the RBC count, it is usually reduced as in compared to the thalassemia, where the RBC count is normal. The reticulocyte percentage may be normal, or absolutely reticulocyte does not indicate any insufficiency. The stool for the occult blood should always be checked to exclude the blood cause for the iron deficiency anemia. Now coming to our major topic, that is the most important thing, prevention. As we all know, prevention is always better than cure. It is best to prevent this iron deficiency anemia. So what has to be done then? The first and the most important thing to prevent this anemia is the breastfeeding. Ensure that all the newborn children up to 6 months of the age should be exclusively breastfed. Encourage exclusive breastfeeding for all the neonates. And after that, the weaning diet and the supplementary diet which they start, the weaning diet, especially which is started at the 6 months of age, should be fortified with the iron. So why? So one things come to our mind. What is the need for this have the prevention of this iron deficiency anemia? According to the survey of the National Family Health Survey, 53% of the pregnant women, 50% of non-pregnant women at the age group of 14 to 49 years, 58% of the children, 29% of adolescent boys, and 54% of the girls are found to be iron deficient. So first, to know this prevention, to do this prevention of iron deficiency anemia, we should know what are the causes, what are the main causes of this iron deficiency anemia. Iron deficiency anemia has basically two important causes in India as far as we are concerned. One is inadequate dietary intake against the very high requirement, and second is the intestinal worm infestation. What is the reason for the inadequate diet intake? It may be low intake of the iron, or it may be high intake of the inhibitors. Second thing, intestinal worm infestation. Mainly that occurs due to the lack of hygienic conditions, healthcare facilities, inadequate care of the girls during menstrual period or during the early period of the conceptions. So it becomes a vicious circle. Adolescent girl enters with iron deficiency anemia into the reproductive age group. She becomes pregnant with the anemia. She gives birth to the baby with the low iron stores or the low hemoglobin level. The anemia does not get corrected with the baby. Again, that baby will develop into an adolescent with low hemoglobin, and this vicious circle will go on. So taking into all this consideration and looking into the importance of the iron, our central ministry has organized or has come up with so many plans. So I will be discussing with some of these national initiatives which have been taken by the central government. First, most important is the NIPI, that is National Iron. National Iron Initiative. It was mainly started by the adolescent division of the Central Ministry of the Health and Welfare, Family Welfare, launched in 2013. The main initiatives in this strategy was these 5 beneficiary groups were there: between 6 to 60 months, children between 5 to 10 years, 10 to 19 years, pregnant and lactating women, and the woman in the reproductive age. They were all given the iron supplements, including with the help of the ASHA workers, Anganwadi workers, and also with the help of the school teachers. Next is the Anemia Mukti Bharat program. It is also known as Poshan Abhiyan, which was launched in 2018. The main was this, as you can see, there is a pyramid which includes 666, like 6 beneficiaries, 6 institutional mechanisms, and 6 interventions. The main aim to 2022. As I have told you, that the children, adolescents in the reproductive age group are made of this, are mainly the beneficiaries. These are the main features of the Anemia Mukt Bharat strategy: a prophylactic iron and folic acid supplementation, deworming, intensified year-round behavior changes, communication campaign, including the ensuring delayed cord clamping, testing for the anemias using digital point of methods, mandatory provision for iron folic acid fortified foods in the public started for the school health children. All the school health children were given a particular day the tablet of iron and folic acid, 100 milligram of elemental iron and 500 microgram of folic acid. It was given on a fixed day in the school or in Anganwadi center for 52 weeks. Next, coming to IEC, that is Information, Education and Counseling Program. That is means information regarding the symptoms of anemia, like we all know that tiredness, headache, palpitations, all these things. Education regarding identification and early referral, like hemoglobinopathies, chronic inflammation, and counseling regarding diet and cleanliness. So why? So whom should we screen, and what are the target groups for the screening? Ideally, all the annual school health checkup should be done, and they are mainly done to identify these children with iron deficiency anemia. So it's Anganwadi workers, all the teachers, all the central workers should be appropriately trained so that they can identify these children and refer or start treatment at the earliest. There are two more important reasons why we have this iron deficiency anemia. One, as I had already told, that hookworm infestation, and second is the malaria. So hookworm, which can be easily prevented with our personal hygiene and environmental cleanliness measures, use of clean toilets, washing practices, and albendazole every 6 months. And malaria, as I had already told, it's a national vector-borne disease control program which has been started, and we can keep clean surroundings, insecticides, and also use of the mosquito nets, avoid waterlogging in the houses, and complete treatment of the malaria can prevent the iron deficiency anemia. Most important thing, apart from all these infections, is the fortification.
Time's up. Time's up.
Yeah, just 2 minutes. Last few slides are there. A fortification of the foodstuff, mainly with the salt, flour, rice, and biscuits. These are some of the iron-rich foods what we are having, and this is how the diet looks like. So mainly, as I told, adults and girls are at more risk for this. So don't let your phone. If you don't let your phone happen this, don't let happen for this. So lastly, coming that, as I had already told, that give less milk. Even the animal milk can also cause this iron deficiency anemia. Now, lastly, coming to the treatment. In the treatment part, as we had mentioned, that simple oral iron supplementation can prevent this iron deficiency anemia. Diet rich in iron, also the living less of animal milk can also prevent this iron deficiency anemia. Oral iron supplementation 1 to 2 milligram per kg in a preventive dose and 3 to 6 milligram per kg per day is recommended for everyone. These are some of the oral formulations and dosing for the oral iron therapy. Also treatment that whenever you give this iron, we should tell the children that they may have constipation, black stool, blackening of the teeth. A few points about intravenous iron therapy. Intravenous iron therapy is usually considered when there's persistent iron deficiency despite of oral therapy. When contraindication to oral therapy is there, some comorbidities are there. So these are some of the intravenous iron preparations which are there. Iron dextran, Feriject, which can be given in this. With the help of this formula, we can calculate the elemental iron and we can give the intravenous iron therapy. This is also a quick dose guidance regarding the oral iron therapy in severe iron deficiency anemia. This is how the response to the iron deficiency anemia is there. In 12 to 24 hours, there is a replacement of intracellular enzymes. Then bone marrow response will be there. In 48 to 72 hours, reticulocytosis, and 1 to 3 months replenishment of stores. So important point, take home message is that for every iron deficiency anemia, give at least 3 months after you complete the treatment, and the oral iron should be continued to responses so that the stores can be replenished. Blood transfusion is very rarely required in case of iron deficiency anemia. Only in case of child having severe anemia with congestive cardiac failure, the blood transfusion is required. Otherwise, remember that prevention is always better than cure. So try to prevent this iron deficiency anemia. Thank you.
Over to you, ma'am. Mamta.
Yeah, so lovely, Dr. Meenal. Despite all your network issues, finally you could manage to present, and you gave a very, complete overview of iron deficiency anemia, though period time is short. Now, a few points. When you said pica is one of the very important symptoms, yes, it is a symptom, but one must always worry about lead poisoning if there is pica where a child is eating mud, soil, because this contains also lead, and lead can also present like iron deficiency, and you may get fooled that we are giving iron, but the patient is not improving. Look for lead poisoning related symptom signs like blue line on gum and, certain other cognitive dysfunctions, abdominal pain. These should be looked at. The point about NIPI, one must all remember that 6 months onwards, every baby should be receiving once a week iron supplementation. Even if they are well fed, better to give it in our lower socioeconomic strata, all children iron supplementation. And in preterms, you may give as early as 4 to 6 weeks onwards iron supplementation. That should be remembered. Principles of management of iron deficiency, beautifully one must remember is treat the iron deficiency, but don't forget to find the cause of iron deficiency and correct that cause. For example, you don't counsel for diet, then the patient is going to recurrently come with iron deficiency because they'll continue the same diet which is lacking in iron. Second is, suppose it's blood loss, And if we don't correct that blood loss, patient is going to come recurrently with iron deficiency. And we might then resort to unnecessarily parenteral iron, thinking that this patient is not responding to oral iron. Or we may even look for IRIDA, that is iron refractory iron deficiency anemia, which is an inherited disorder of TMPRSS6 mutation, which we should not hurriedly do because that is very rare. It's not as common. So I think with these points, I will hand over back to the moderators. Thank you.
Thank you, ma'am, for such clear message. And over to you, Dr. Sonali, for further moderation.
Thank you. Moving over to our another speaker, I would request Dr. Atish Bakane, sir, from Nagpur IIP. He is a senior consultant and head of the department at the Hemato-Oncology Department and Bone Marrow Transplantation Center at New Era Group Hospitals, Nagpur. He will be speaking on stem cell therapy, indication of SCT in pediatric hemato-oncology. Over to you, Dr. Atish. Kindly unmute. Kindly unmute.
No, am I audible and is the screen
Yes,
visible?
yes.
So, good evening, everyone, and thank you very much, Team IIP, for giving me this opportunity. So, I would be very brief because indications of hematopoietic stem cell transplant in children is a big topic because the list of indications being very elaborate. So, we know that bone marrow transplantation is an evolving science, and so are its indications. Initially, it was mostly done for autoimmunity and some leukemias, malignant diseases. But subsequently, many of indications, many investigators thought that this can be applied in different indications. So, this modern era of BMT offers treatment for many malignant and non-malignant indications. There has been a refinement of indications for multiple conditions. So there are different bodies which decide about the indications of transplantation, like American Society of Transplant and Cellular Therapy, European Blood and Marrow Transplant Unit, and our own Indian Council of Medical Research. So there are so many bodies which have come up with different indications, and the science is now evidence-based. Everything is evidence-based. So you cannot go and do transplant for everything. So what will be the benefit of that transplant is to be understood first. So for that, or for that matter, for any treatment, there are specific indications and specific guidelines set by different bodies. So standard of care, we know standard of care means there is enough evidence with high quality clinical trials and observational study that this will be definitely beneficial. Some like standard of care with some clinical evidence available. So here there will be there is sufficient data to see that this would be helpful. Sorry. And there are some indications in indications are developmental, where only preclinical studies or early phase clinical studies have proven that it may be beneficial. And there are few indications which are where general transplant may be done, but it is not generally recommended. So as per suggestions from our Mamta ma'am, I have kept very short, and 2-3 topics I have chosen over this because it's a huge list of indications. So because we are dealing with thalassemia day. So thalassemia, in thalassemia at present, allogenic transplant is indicated. It was started by Pesaro group in 1980s. And these patients, initially they divided in few groups. So they had looked at different problems, whenever the patient comes, we usually examine them from hepatomegaly. We look at them whether there is a portal fibrosis, and we always see for the chelation history. So looking at these factors, we classify them and we can take them for transplant. So there are different classes, class 1, class 2, and class 3. Initially, the outcomes of class 1, class 2 were good, but class 3 were not doing well. So in class 3, there are different technologies which advanced, and many people have done in different way. So in the current scenario, the thalassemia kid, the treatment, the standard of care treatment is transplant. So coming to sickle cell disease, because I belong to area where sickle cell disease is huge, as madam has explained that there are few patients who need transplant in sickle cell disease too. I beg to differ in the severity of sickle cell disease in our area, because I have been seeing these patients since last 20 years in our area. So many of the patients who are really severe, they come to us in OPDs. They are receiving hydroxyurea in optimal doses. So almost to the tune of 20% patients, they do not respond to hydroxyurea even in our Vidarbha region. So the specific indications have been laid down by multiple people. Our own Shalini Shinoy and Lakshman Krishnamurthy were few authors among this. So stroke, any CNS event lasting more than 24 hours, multiple acute chest syndrome, recurrent veno-occlusive crisis, impaired neuropsychological function, multiple acute chest syndrome, sickle nephropathy, any end organ damage can be taken as a transplant indication in sickle cell disease, obviously. So few more indications were added in sickle cell disease transplant, because the medical care is so suboptimal, because we get in Vidarbha, Nagpur, I get patients from Gadchiroli who many patients do not reach acute, they develop acute chest syndrome, somebody gives transfusion, they do not reach us. So many new indications have been added in sickle cell disease transplant. So we should know about our own ICMR guidelines. They are mostly, there are some differences in ICMR, EBMT and ASTCT guidelines. So we should know about ICMR guidelines. In thalassemia and sickle cell disease, matched sibling donor or matched unrelated donor, these are very well accepted. Out of this, matched related, that is matched sibling, is a standard of care where evidence is very strong. And subsequently, MUD, mismatched allogenic alternative donor transplants also are being done with good success nowadays. Although I think it is maybe few years before we make them standard of care, because there are many patients do not get the donor in India, particularly even in families. If we don't get the donor, we look for in the different registries. In some patients, like almost 70% we get the donor, but in 30% of the patients we don't get. So other indications are being thought of. Severe aplastic anemia is very important. This is one dreaded disease, we know. So I think there is one major criteria which has to be, I think one even pediatrician should know, because the pediatrician at the outset should be able to differentiate whether it is looking like mild to moderate or severe aplastic anemia, and refer the patient early. So the severe aplastic anemia, in the current scenario, transplant, the best in pediatric severe aplastic anemia, bone marrow transplantation is the cure, because it has been the first standard of care treatment is matched sibling donor. Sometimes if it is not available,
I think network issue is there. I would request Manglani ma'am for her expert comments about this topic.
Yeah, so I think he would have covered more conditions, but maybe if he comes back, we can complete it. But as we know, HSCT in pediatric practice is something phenomenally improving the outcomes in various conditions, especially thalassemia, sickle cell disease, aplastic anemia, as he was talking of, and many malignancies, especially leukemias, ALL, AML, which are relapsed refractory. These are the conditions. Lymphomas, we do autologous transplants. Mainly was talking of allogenic transplant, but autologous in solid tumors like neuroblastoma and in lymphomas also is a huge success story today. In fact, neuroblastomas used to have a stage 4 high-grade neuroblastoma used to have an outcome of 10% beforehand. But with autologous transplant, it has gone up to 30% to 40%. And with anti-GD2 antibodies that are a new modality of treatment, it has gone up further to almost 70% outcomes. I would just make a couple of comments about aplastic anemia because that is very applicable to general pediatricians who are seeing patients in their practice. When you see a severe aplastic anemia patient, try and give minimum transfusions before referring to a transplant center, so that don't delay the referral, because the more the number of transfusions this child would receive, more the chances of HLA alloimmunization and alloimmunization and refractoriness to platelets, and that will cause trouble while transplanting. Patient may not accept the graft and may reject. Second part is in aplastic anemia patients, infections can cause such quick deaths that you must not allow the patient to stay with you for too long before referring to a transplant center, so that he gets transplanted before infection hits him, especially fungal infections. We have seen children dying of fungal infection even after reaching our center for transplant, because there's a waiting period of maybe 8 days for pre-transplant workup. So if you refer fast, then obviously we as transplant centers can quickly take this patient up, especially if there's a matched sibling donor. There's no reason why we should wait if there's a matched sibling donor. If there's no matched sibling donor, then if we are waiting for MUD, we might lose the patient. That is matched unrelated donor from a registry. Here again, I would say sometimes a haplo transplant may be worthwhile without waiting for a MUD donor. So that is my message, that's aplastic anemia, refer to the hematology bone marrow transplant center as early as you can if you want to save lives, and really you can save lives. Older children with aplastic are more likely acquired. Younger children are likely to be constitutional bone marrow failure syndromes in whom anyway other treatments will not work. So therefore, best is to send them. Use irradiated blood products for every patient who is going to be peri-transplant or pre-transplant. Even in thalassemics, for at least 3 months prior to transplant, you can use irradiated blood products. And leukofiltered, of course, should be a standard of care for any blood products. I think I'll stop here because we have to complete one more talk. Atish is back also. Maybe he can complete whatever slides as you like, Sonali.
Yes, madam. Dr. Atish sir, are you there? I think he had not joined.
Is the screen visible?
Yes, yes. You can continue from where you have left.
Yeah, yeah. Oh. So I think only last 2 slides were remaining, because as I told you, there are a lot of indications. So malignancy is one indication in pediatric age group. So discussing about the indications in malignancies will be out of scope here. But yes, whenever particularly high risk leukemias, these are the patients where we sometimes we offer upfront transplant, or particularly in relapse settings, we go for transplants with different outcomes depending on what type of transplant and what type of disease we are dealing with. So subsequently, there are other malignancies, like I discussed only about leukemias, but solid tumors also, where most of the times we go ahead with autologous stem cell transplant or autologous stem cell rescue rather, because in solid tumors, sometimes we have to give very high dose chemotherapy, where unless we give some sort of stem cell rescue, it is difficult to make them survive. So these are particular indications where we go ahead with autologous stem cell rescue. And a word about second hematopoietic stem cell transplant. Sometimes second hematopoietic stem cell transplant is also considered particularly as a clinical option in patients where sometimes if the patient relapses post-transplant in malignancy, there are subsequent transplants which have shown that if you do in a different way or different things, if you use, we can still salvage the patient. Or particularly in case of graft failure, if there is a graft failure initially, whether it is malignant or benign disease, with tweaking in conditioning, we can go ahead with a second transplant, and in that also we can succeed sometimes. So thank you very much. Pardon me for my interruption. My daughter switched off the net connection outside.
Oh, that's an interesting pediatric problem.
First time something different reason was there. Thank you, Atish sir. Thank you, Manglani madam. Moving on to our last speaker, I would request Dr. Chetna Bahurupi from Ahmednagar IIP. She is a pediatrician and neonatologist at Ahmednagar. She is director at Nucleus Children and Research Hospital, Ahmednagar. She will be talking on aplastic anemia, immunotherapy of aplastic anemia. Over to you, Dr. Chetna Bahurupi.
Yes, ma'am.
Please stop screen sharing. Dr. Atish sir, please stop screen sharing. Yes. Over to you, Dr. Chetna.
Yes, shortly. First of all, I would wish good evening, everyone. It's being late, I know. Thank you, Maha IIP Women's Committee team, for giving my district this opportunity to present myself. My topic is aplastic anemia and its immunosuppressive therapy. I would also like to thank Dr. Mamta Manglani ma'am for tremendous help and giving her precious time for the PPT, making PPTs. This is not getting a full screen.
Okay, you can continue.
Okay. Ma'am, is it sharing? Can you see?
Yeah, we are sharing. We are viewing it. You can click on slideshow. No. After animations, there is slideshow.
Ma'am, this bar actually is, yes.
Okay, you can continue your topic. Yes.
Just a second, ma'am.
No, click on from current slide. You have clicked slideshow now, huh? From current slide. Second. Yeah.
Thank you, ma'am.
Welcome.
So, aplastic anemia is a bone marrow failure syndrome characterized by multilineage cytopenias and severely hypocellular bone marrow without infiltration of the disease of the bone marrow. It has a biphasic distribution. The first peak arises around 10 to 25 years of age, and the second peak arises around 60 years of age. So, in the slide, we can see there is a normal marrow, and here it is a hypocellular bone marrow picture. Mostly Comita's criteria classify the aplastic anemia into severe disease, very severe disease, and non-severe disease. In severe disease, bone marrow cellularity is less than 25% and more than or equal to 2 of the following. Peripheral blood neutrophil count should be less than 500. Peripheral blood platelet count should be less than 20,000, and peripheral blood reticulocyte count should be less than 20. Very severe disease above, all above, but peripheral blood neutrophil count should be must be less than 200. In non-severe disease, hypocellular bone marrow with peripheral blood values not meeting the very severe criteria of aplastic anemia. So, aplastic anemia acquired cause remains the most common cause for aplastic anemia because it is caused due to cytotoxic destruction of the T cells of the hematopoietic stem cells. So, always aplastic anemia need to be classified or differentiated from the inherited bone marrow failure syndromes while treatment. So, aplastic anemia must be distinguished from other causes of pancytopenia. Inherited bone marrow syndromes may be associated with extra hematopoietic manifestations and high risk of development of acute leukemia, myelodysplastic syndromes, etc. Management of aplastic anemia is completely different from the inherited bone marrow failure syndromes and other causes of aplastic anemia. So we will discuss now common causes of acquired aplastic anemia as well as inherited causes of the aplastic anemia. So idiopathic remains the leading cause for acquired aplastic anemia. Then secondary causes are radiation, chemotherapy, drug toxicity, idiosyncratic reactions due to anti-inflammatory drugs, anti-epileptic drugs, viral infections like Epstein-Barr virus, HIV, and hepatitis virus. Also, immune-mediated diseases like systemic lupus erythematosus and eosinophilic fasciitis leads to aplastic anemia. Also, conditions like pregnancy, PNH, myelodysplasia can lead to aplastic anemia. Here, I would like to talk a few seconds on hepatitis. Hepatitis is the leading second cause of acquired aplastic anemia. Generally, post-hepatic viration after post-hepatitis, from 15 to 45 days, symptoms of aplastic anemia starts, and this has most poor prognosis in the treatment. And then inherited causes are Fanconi's anemia, dyskeratosis congenita, and diamond blackfan anemia, reticular degenesis, etc. So finally concluding the aplastic anemia, we need to do certain laboratory tests. Complete blood count with differentials, reticulocyte count, liver function test, serum folate and vitamin B12 levels, viral markers. In complete blood count, we can see the pancytopenia with differential. In differential count, we can see the low neutrophil count. Also, dysplastic neutrophils can be seen in PBS. Then, in bone marrow examinations remains the most important treatment modality here. Examination. Microscopy and histopathology confirm the diagnosis of aplastic anemia. Cytogenetic and molecular evaluation for myelodysplasia syndrome can also be done. Then special investigations, flow cytometry of peripheral blood for paroxysmal nocturnal hemoglobinuria clone. That is, if in CD55 and CD59 deficient leukocyte cells are circulating in the blood, if these are less than 50% of the 50% in circulation, then it points towards the acquired cause of PNH clone, and this patient respond more to IST. Chromosome breakage test with dioxybutane or mitomycin C to rule out Fanconi's anemia. Telomere length analysis is done to rule out DKC, that is dyskeratosis congenita. Genetic testing by NGS is done to differentiate between the inherited bone marrow failure syndromes and acquired causes of aplastic anemia. So whenever a patient of pancytopenia approaches towards us, so first of all, we should do bone marrow biopsy. Histology will rule out leukemia, metastatic cancer, and other conditions like identified marrow hypoplasia. Then bone marrow aspirate can be sent for cytogenetics and FISH to identify chromosomal abnormalities. Then peripheral blood count will show neutrophilic decreased neutrophil count, and to assess the severity, disease severity. DB test to exclude Fanconi's anemia, determine proportion of GPI negative cells. This after all the tests, we can come to a diagnosis of acquired anemia. First of all, as sir said, we will require a matched sibling donor in the family for treating the anemia, acquired anemia, aplastic anemia. Then choice of treatment wholly depends on the matched sibling donor, finding a matched sibling donor. If there is a matched sibling donor, then we will go for bone marrow transplantation. And if there is no matched sibling donor, then we will go for immunosuppression therapy. That remains the first line treatment. So who are the candidates for immunosuppression therapy? So these are not having HLA matched family donors or unrelated donors, and preferred patients are not medically fit for allogenic hematopoietic stem cell transplantation. What does IST includes? IST includes or antithymocyte globulin, that is ATG, prednisolone, cyclosporin A. So antithymocyte ATG can be given the dose of 40 mg per kg per day for consecutively 4 days. Before giving ATG, one should do hypersensitivity testing. It is given in the infusion for 12 to 18 hours per day. Then prednisolone is given to prevent and control serum sickness. Initially, there was wrongly thought that high doses of methylprednisolone are required. Initially, 10 to 15 mg of methylprednisolone was given, but it led to much of the complications and bacterial and viral fungal infections. So now only minimal dose of 1 mg per kg per day is given, that too in a divided doses, and can be continued for 10 to 14 days. And later we can taper it slowly. Cyclosporin A is given. Cyclosporin A is begun on day 1 of the dose, day 1 of the treatment, given at the dose of 5 mg per kg per day to maintain target blood level through 100 to 200 microgram per ml. We have to watch for nephrotoxicity and other complications. We can continue cyclosporin treatment for complete 1 year. Now, over a period of time, there has been an evolution in the treatment IST. In 1970s, we can see here on the left-hand side, in 1970s, along with an ATG, androgens were used, but the response rate was very less, around 56%. And also the complications were more, leading to hepatotoxicity and muscarinic effects in the females. Later, with the introduction of cyclosporin, there was change in the treatment, and cyclosporin was combined with ATG, showed marked improvement in response rate with 70%, which was initially 41% with only ATG. Then also in non-severe aplastic anemia patients, trial was given with CSA and ATG. So it also showed marked response rate of 74% as compared to 46% initially. Also, GCSF was introduced along with cyclosporin and ATG, but it didn't give much of the response rate. Response rate was only 60 to 70%, and it was been reserved for the refractory cases. So also immunosuppressing agent like sirolimus and MMF were given. They also didn't show marked improvement or marked response rate, so they were reserved. There was a trial between rabbit ATG usage and the horse ATG usage. But rabbit ATG had given response rate of only 37%, whereas and also the complications of rabbit ATG were more. Rabbit ATG causes marked profound neutropenia and CD4 lymphopenia, which led to marked increase in the infections and marked increase in the mortality of the patients. So its usage was stopped. Secondly, it also led to a prolonged CD4 lymphopenia led to prolonged duration of the treatment. Patients were not it took longer duration as compared to horse ATG. So usage was stopped. Also, after ATG transfusion, there is reactivation of CMV and EBV viral infection. Rabbit ATG usage led to severe reactions of EBV and CMV. So that also led to increased mortality in the patients. So its usage was completely stopped, and always a horse ATG was preferred over a rabbit ATG. In 2015, there was marked evolution in the treatment of IST that led to Altrombopac introduction. Altrombopac is the thrombopoietin agonist. Along ACE, that is ATG with cyclosporin and Altrombopac, has given marked increase in the survival rate, increased in the decrease in the lower relapse rate, and also early response is seen. So we can here see there was one trial. Group A consisted of historical IST, consisting of ATG and CSA, and Group B was added with historical IST plus Altrombopac. So you can see in the slide, event-free survival was more in the Group B, leading to increased survival rate. With the Altrombopac addition, 90 to 95% of survival rate was seen. Supportive care is always required during transfusion. Transfusion with platelets. Patient is bleeding and platelet less than 20,000 is indication for platelet transfusion, and less than 10,000 is also indication. ATG also causes lysis of platelets, so before ATG transfusion, platelet levels should be maintained between 20 to 30,000. Also, if HB is less, then packed cell RBC should be transfused. Preferred are leukoreduced, as ma'am said, leukoreduced blood products, and which prevent HLA aluminization, and irradiated blood products should be used. Febrile neutropenia can be managed with broad spectrum antibiotics. Antifungal prophylaxis should be given in severe neutropenia patients with ANC count less than 500. Azole group of antifungals can be used. Antibacterial prophylaxis is a bit controversial. Myeloid cytokinins is reserved for the patients with ANC absolute neutrophil count less than 200. Take home is outcome. Treatment with IST in children with severe aplastic anemia is associated with approximately 90% long-term survival rate. Only 1/3 to 1/2 of children achieve CR. Many require salvage SCT for relapse or refractory diseases. 5-year event-free survival is 62%, and there was no plateau, apparent plateau, even after 5 years. So this is in short a picture diagram. Here we can see if there is a matched sibling donor. First, we must go for matched sibling donor BMT transfusion. But in case we didn't get it, then we can go for UDBMT. And if this option is also not possible, then we can go for ATG plus CSA transfusion. If the patient age is more than 60 years, then ATG and CSA remains the main line of treatment. Take-home messages: early diagnosis, early referral, early treatment, better outcome, and more survival rate. Thank you.
Yeah, thank you. Yeah, thank you, Dr. Chetna. I think you really have talked like a hematologist, so I must compliment you.
It's all because of you, ma'am.
No. So I just would add a couple of points here. Is one thing is, I think you said 90% outcome long term. It's I think 40 to 50% outcome long term, and initial outcome is 80 to 90%, but they wane off with time. And Eltrombopag has made it up to 50 to 60%. Earlier, it was even lesser than that 5-year survival. But therefore, we must aim to do transplant in as many patients as possible. As I earlier already said, any patient who is not responding to IST should go for alternate bone marrow transplant. Haplo is also good enough. We have been doing haplos even at our center. For the only indication where I am very liberal with haplo is aplastic anemia, and I'm sure Atish will bear me out on this. So I think in aplastic, otherwise IST has almost been given up. I think I have used it sparingly in a couple of patients recently because we try to do transplant as much as possible. But yet it is an option, and with Eltrombopag available, it has become a good option, and we must not give it up totally. Androgens have no role today. And another thing which I want to tell you all, unless you have done stress cytogenetics in every patient upfront who is diagnosed aplastic and ruled out Fanconi's, done a clinical exome to rule out inherited bone marrow failure syndromes, please do not use IST because it is a waste of money and time, both. So better than to go for transplant upfront. And there again, haplo is justified if you do not find MSD, MFD, MUD or MMUD. All these, if you don't find, then go for haplo transplant. I think these would be my 2-3 messages. And with that, we can wind up. Thank you so much, all of you, for lovely presentations, and it's been an enjoyable time.
Thank you. Thank you very much, madam. Any questions in the chat box? I think there are no questions in chat box. Anyone would like to ask question?
So someone has asked about ferric ascorbate. Ferric ascorbate has, well, it is not a bad compound, but it is not better than ferrous sulfate or ferrous fumarate. So I still would go on with ferrous fumarate and ferrous sulfate. Giving less iron or requiring less iron, I don't think it is true. The dose is still same for elemental iron.
Ma'am, many patients ask us where to go for the government sector, where to go for the bone marrow transplants. So we are clueless.
Yeah. So if you really ask me, I always say this, that there is hardly any public sector transplant center in the country. most of the public sector transplant centers are the centrally aided autonomous hospitals like AIIMS, PGI Chandigarh, SGPGI, etc. But these are not truly public sector in the true sense. In Maharashtra, in public sector, I think we are the only one where we do free of cost transplants for non-affording patients. So one is our Borivali Center and the second is at Sion Hospital, which also was started when I was head of department there. And the Borivali Center Transplant Center has already done 275 and more transplants at no cost or nominal cost to patients. So you can refer your patients to us. If you can refer to Ambani, they would do through Coal India. There is a Coal India Limited with Ministry of Health and Family Welfare project under the Thalassemia Bal Seva Yojana, where for all thalassemia patients below 12 years of age and any aplastic anemia patient below 18 years of age, if they have a matched sibling or a matched family donor for aplastic even MUD, then they would support with 10 lakh rupees. So even Ambani Hospital is doing, and there are many other in the country. I don't have the list offhand in my mind, but 10 centers have been given. So you can refer to those places also.
Yes, ma'am. But for how long patient has to wait for that his turn to come?
So if it is aplastic, we fast track. We don't make them wait because we don't want to lose them while they're waiting. But if it's a thalassemia patient, then there is no harm waiting 1 year also. And our wait list now is about 6 months. For thalassemia patients, it is about a year.
Madam,
for leukemias and all, we fast track. Yeah, sorry.
Yes. Madam, what are the special, in every thalassemia patient, are we doing bone marrow, or are there any specific indications that bone marrow should be done in this thal patient?
So all transfusion dependent thalassemics should be offered a transplant upfront. At diagnosis itself, counseling should begin with the parents. Of course, we don't do transplant till 2 years of age at our center, but I have seen centers doing at 6 months, 10 months, 12 months, whatever. So you can counsel a patient once you are sure this is a transfusion dependent patient, not a non-transfusion dependent. And for that, you must give a period of waiting of at least 2 weeks. And between the two CBCs, if the hemoglobin is not below 7, then do not consider them as transfusion dependent immediately and wait and watch and just give transfusion when the hemoglobin drops below 7 second time. And then put them on transfusion if it falls below 7 without any infection or any other cause for drop in hemoglobin. So that's how we would decide about transplants. But yes, they should be given the choice of family donor transplant. At the most MUD, I am not yet happy with haplos in thalassemia because there is a high chance of rejection. There's a high chance of mortality and complications, chronic GVH. All these make their quality of life worse than with conventional treatment. So when there is conventional treatment available, which can be given happily, they can live up to 50, 60 years with that, or they can survive at least till some new therapy comes up, which is easier to deliver, then we should do that. But treat them ideally. I think talking on thalassemia, I can go on for all night, but time is limited. But yes, this is what we must do. Treat them well to maintain them well. And those who can be transplanted should be transplanted.
Yes, ma'am. Thank you, madam, for your valuable inputs and guiding us all the time for all the speakers and as well as for question and sessions. Thank you really very much, ma'am. Over to you, Neha, for a vote of thanks.
Yes, thank you, Sonali ma'am. Today we had a mega blast program. I, Dr. Neha Singh, co-chairperson on behalf of MahaIP Women's Committee. First of all, I with whole heart like to thank Dr. Mamta Manglani ma'am and Nitin Shah sir for accepting our invitation for being the expert of our today's program. Both have given their guidance to all the 5 speakers and kept track of each presentation. Later, because of some important work, sir was not able to join us today. But ma'am, your expertise, comments and guidance was really very helpful to us. Once again, thank you so much, ma'am, for being part of MahaIP Tuesday Tech. I would like to thank MahaIP President, Dr. Ramakant Patil sir, Secretary General Amol Pawar sir for giving us their support and MahaIP platform. I thank Dr. Hemant Gangulia sir, Dr. Renu Boralkar ma'am, Dr. Shyam Chaudhary sir for joining us today and motivating us. I thank Maharashtra Medical Council and our MNC observer of today, Dr. Prashant Dane sir, for joining us and also granting all the participants 1 MMC point. I thank all the 5 speakers of today, Dr. Purva, Dr. Meenal, Dr. Shraddha, Dr. Atish, and Dr. Chetna for preparing beautiful presentations and delivering their topics excellently. Congratulations to all 5 of you. Also would like to thank our Women's Committee Chairperson as well as today's moderator, Dr. Sonali Shirvate ma'am, Dr. Suchita Phupale, for wonderfully moderating today's program. Also, thank you, Dr. Manjusha ma'am, as well as other moderators of members of Women's Committee for helping in organizing today's program. Thank you all. Thank you all the EBs and OBs of MAHA-IP for joining us and giving their full support. Thank you, Pallavi ma'am, for giving us the digital support. Last not the least, all the attendees on Zoom and live YouTube channel for joining us. Requesting everyone to join our next Tuesday on 20th June. Thank you. Good night.
Thank you.
Thanks.
Really, there was a woman power today. We can learn lot